Hello, everybody. This is Mahdi. I'm one of the tutors with the Match Guy, and today we are going to discuss uh, some of the questions of the high-yield questions related to the psychiatry system. We'll go over them. We'll discuss them together. I want you guys, once I finish reading the question, I want you to write your answers on the chat, and then we'll start discussing and talk about other important questions that can be asked similarly and all of the important things that you basically need to know regarding this. So let's start with the first question. So the way I like to approach questions, and that varies from one to another. I would like you to follow like different and try different approaches and see which one works for you. But what works for me is that I like to treat the patient. I like to look at the question as if the patient is actually coming to the clinic. So I like to read the first sentence and then read the two sentences to see what they are looking for, look at the answers, and then go back read the question if I feel like I still need to. So let's start. So a 20-year-old man, let me try to make it zoom in a little bit. Yeah, I think that's better. Do you see the screen clearly? Do I need to zoom in more? Yes. So a 20-year-old man is brought to the emergency department by his friends because of bizarre behavior for the past 2 hours. The friends report that there were a social gather. That's the first sentence. Then I like to read the last two sentences. Pupils are 4 millimeters, reactive to light. Neurological examination shows no focal deficits, though he performs poorly on the finger to nose test. Which of the following is the most likely substance responsible for the patient presentation? And this is the 20-year-old, and the friends report that they were at a social gathering when the patient began laughing uncontrollably in appropriate times. Shortly after, he became withdrawn, expressed concern that the police were bugging the vents in the room. He also requested several bags of potato chips and drank a large amount of water. On physical examination, the patient appears relaxed but slightly distracted. Temperature is normal, blood pressure is normal, pulse is 108, and the respiration is 14. Physical examination shows significant bilateral conjunctival injection and dry mucous membrane. So, which of the following substances is responsible for the patient presentation? What do you think? Yes, some are saying C, some are saying D, but the correct answer is that this is marijuana use, and that is the correct answer. Why? Each of the substances that cause abuse, they all of them tend to have very similar overlapping symptoms. But in order for you to answer the question correctly, and in order for them to make the question reasonable, they basically have to mention key points that helps you reach the diagnosis. So, for example, for marijuana intoxication, they have to mention something related to increase the appetite and conjunctival injection. These are the main clues for that. Because all of the other symptoms related to poorly finger to nose testing, these things can happen with other diseases as well. Having bizarre behavior can happen, I mean, with other substances. But to answer these questions and while studying them, you need to know what exactly is characteristic of each substance that will help you differentiate it from other causes rather than overwhelming yourself with memorizing the overlapping symptoms that you can see everywhere. Where can you find these? You can find them in summary tables in our QBank, and also you can find them in our PDF files. In our PDF files, we have a psychiatry file. You can request it, it's for free. And it's basically there is a table there discussing just the important features in each of the substances that are actually now helpful in answering questions rather than memorizing things like euphoria. This happens with everything. Hallucinations, this happens with everything. But when it comes to marijuana, yes, there will be hallucinations, but what's characteristic about it is the increasing the appetite and the conjunctival injection. Whenever you see that, this is like a buzzword for marijuana use. So if we were to talk about the other answer choices like cocaine, what would be the buzzwords for that? Hallucinations? Yes, you can find hallucinations in other diseases as well. But what would be characteristic of cocaine? It would be things like cocaine is sniffed, so it will be things like nasal septum abnormalities or nasal septum perforation, right? What else? Of course, the sympathetic stimulation that's more significant with cocaine. Also, it can be presented with acute coronary syndrome, for example, because of the vasoconstriction that can happen due to cocaine. Also, sometimes it will be presenting with severe hypertension, and that hypertension can even progress to cause intracranial hemorrhage, for example. But for cocaine, I would say the most characteristic things are the severe sympathetic activation, like very noticeable sympathetic activation, plus the nasal septum perforation, plus the cardiac symptoms of any. Okay. Yes. Now, what about the heroin use? Heroin use, what would be regarding heroin use? Some of you guys are saying pinpoint eyes. No, pinpoint eyes, that's with heroin use. While my cocaine would be associated with sympathetic stimulation leading to mydriasis. There will be dilation in the pupil. But for heroin use, this is the one that's associated with the respiratory depression. Okay, I'm talking about respiratory depression in intoxication. It will be associated with constipation. It will be associated with pinpoint pupil. And these are basically the main characteristics. And of course, they decrease the pain sensation, and that's what they are used for, the opioids in general. Also, sometimes they ask about withdrawal. So, characteristic features of withdrawal is flu-like symptoms, piloerection, okay, and what else? Piloerection, um, and flu-like symptoms associated with GI pain and diarrhea, and sometimes fever. And also, it will be associated with um, heroin use withdrawal, would be associated with cravings also for heroin, and also piloerection, which is basically that there will be erection in the hair follicles in the hand. What about LSD? LSD intoxication is associated with this. Hallucinations. Okay, we know all of them is associated with hallucinations, but LSD is particularly associated with flashbacks, and that's what makes it characteristics. Flashbacks and sensation of depersonalization and derealization. They feel like they are detached from their environment, and they detached from their body and from who they are. And then PCP intoxication, the characteristics of this would be that they have decreased in the sensation. So that would lead to analgesia. And also they will be super violent. And you can imagine if someone is violent and they have decreased sensation, with this combination, of course, they are at an increased risk of trauma. So they could ask you, what is the most common complication, which is trauma, or they can mention trauma in the question along with decreased sensation. Now they you know that they are talking about PCP. Someone is asking where they can get the PDF files. You can get them by emailing you can find them on the website of the Match Guy, and you can also get them by emailing our email at the Match Guy. It's called info@thematchguy.com. You'll find it on the website, and also you can open the website, the free resources there, and they will start sending it to you. Cordero, Michael, is there a group chat for learners? We would love to join a study group. Well, in our QBank for subscribers, we have a QBank, we have a group chat for all of the people who are studying, and in our QBank there is a community there. But I'm not sure that if there, I don't think that there is a community just for anybody to join. It has to be for people subscribed to the QBank, and there is a community there. And I really advise you guys to purchase the QBank, because what we are introducing here is not like uworld, it's not like amboss. This is a focused QBank, focused on the high yield things, because our approach is the minimalist approach. We try to give you what you need for you to pass the exam, not just pass it comfortably and pass it with confidence. In uworld, for example, I see that there is around like 10 blocks of neuro repeating the same concepts again and again. We're trying to make your journey shorter by this QBank, which is 1300, only 1300 questions. And we made it this way deliberately so that your journey is much simpler, and you just have to study it really carefully while studying all the answer choices and study all of the information that's mentioned there. And instead of overwhelming you with doing blocks, hundred, like tens of blocks through weeks and months, we're basically trying to make it easier through this new approach that I think works the best, and you can try it yourself for free, and you can see if you like it or not. Corridor is saying, if you do just the QBank, is it enough? I just bought it and I have 4 weeks. Last two questions. Yeah, of course, you can ask as many questions as you want. I think it's enough if you study it carefully and know everything in it and do MBMEs after, and the MBMEs are reassuring. In that case, it's enough. You can only consider yourself ready through the MBMEs, in my opinion. Okay, so you have to do MBMEs after the QBank to make sure that you have got the passing score. And I also, since you're examining in 4 weeks, I think that you could also think about our crash course. It's very affordable. You basically, our crash course goes over all its 67, 65 hours of live teaching with live tutors, like this session today. We'll basically go over the all of the important high yield concepts for step one in just 1 week. So in this, if my exam were in 4 weeks, I would highly recommend that because it's basically you will just your exam is really close, and that will really provide a nice summary for all the things that you need to know for the step one. Along with this QBank, I think it's more than enough, and you can also make sure by doing ABMs after. Okay, let's see the next question. A 26-year-old woman presents to a new primary care physician to establish care. Okay, so she's coming to establish care. I like to read the last two sentences. The patient initially praises the physician, kind eyes, and obvious brilliance, but becomes abruptly hostile and cold when the physician suggests a screening for mood disorders, stating that I knew you would be just like others who did not want to help me. Which of the following the most appropriate long-term management for this patient? She's visibly distraught and states that her previous physician abandoned her by moving to a different state, adding that he was the only person who ever cared and now I have no one. When the physician asks about her medical history, she mentions several unfortunate accidents, including a recent visit to the emergency department for a fractured hand sustained after she punched a wall during an argument with a coworker. She admits to frequent shopping binges where she spends beyond her means to cope with the persistent sense that her life lacks a real substance. She has changed jobs 4 times in the past year, citing toxic environments, betrayal by supervisors. During this physical examination, the patient notes several circular hyperpigmented scars on the upper thighs. The patient's initial praises, the physician kind eyes, and then she turned it over him once he said that she could have a mood disorder. So, what is the long-term management for that patient? What do you think that this patient could have? With that patient, let's look at what is the problem with that patient. She's shifting in her opinion very quickly, and she thought that the physician is amazing, kind eyes, and brilliance. And once he said something else, she basically became the complete opposite. Also, she seems that she can't control her emotions because once she got angry, she basically fractured her hand while punching the wall, and that's extreme. And also, there is cutting. There are signs of cutting here. Note several circular hyperpigmented scars on the thighs, like she's hurting herself, probably as a compensation for this behavior or as a compensation for her emotions. So, what do you think it is? This is a borderline personality disorder. What's a borderline personality disorder? It's a patient who had these extreme emotional uh, um, actions. Basically, they can't control their impulsive actions and their emotions. When someone gets emotions, they can calm themselves down, they can think about them. This person, just extreme with their emotions, they can do dangerous things like cutting themselves, and also they seem to be really attached and very emotional when it comes to personal relationships, as you can see here. And also they show something here called splitting. What's splitting? It's basically viewing things are either good, very good, or very bad. Everything is black and white. There is no gray area in between. The physician was kind, with brilliance and like that, and suddenly they are to the black side once they start mentioning mood disorders. So that's called the splitting, and all of these are confirmatory features that this is borderline personality disorder. So what would be the treatment of borderline personality disorder? It's a type of treatment known as you guys mentioned, dialectical behavioral therapy. What's dialectical behavioral therapy? That's basically that you talk to the patient and you try to teach them how they can control their actions. And that's what dialectical behavioral therapy is about. Yeah, and this is very important. And another important personality disorder that you need to differentiate from this condition is dependent personality disorder. This is also a patient who is emotional, but they are basically the emotional aspect comes from dependency. They can't handle life alone. They always need someone by their side. They always need someone to take their decisions for them, to do things for them, to manage their daily livings, and that's called dependent personality disorder. This also can lead to unstable relationships and also can lead to a patient getting stuck in an abusive relationship. The reason I'm mentioning it needs to be differentiated from borderline personality disorder because borderline personality disorder can also present with problems in the relationships in the question, but one is more related to controlling emotions and black and white thinking and basically hurting themselves because of these impulsive emotions. The other one is related to getting stuck into this relationship, even though it might be abusive and they cannot do things on their own. So make sure to differentiate between these two. Let's see the next question. A 13-year-old boy is brought to the physician by his parents for behavioral evaluation. Okay. Let's see. When asked how he has been feeling lately, he shrugs and says, I'm fine. I don't know why my parents are making such a big deal out of everything. His current weight is 48 kilograms and his weight was 54. Temperature is normal, blood pressure is normal. Which of the following is the most likely diagnosis? So let's read the question again. After looking at the answer choices, let's read the question. The parents report 3 months history of increasing interpersonal conflicts, noting that the patient is frequently argumentative and easily frustrated by minor requests. He recently stopped participating in his school basketball team. I see what this could mean may be leading to. That could be a depression, and they are starting to describe symptoms. Whenever I see a question like this, I start counting, especially in psychiatry, to know if it's aligning with the diagnostic criteria of the disease in mind or not. Because as you know, in psychiatry, all of the diseases have diagnostic criteria related to the duration and the interval of the disease, like whether it's lasting more than 2 weeks, more than 6 months, less than 6 months. That would be very helpful in differentiating, and also whether they have a certain number of symptoms that they need to fulfill before you consider them having a certain diagnosis. So in that case, with these parents complaining about that child in that case, and he has loss of weight, as you can see, I would say that this is maybe pointing toward depression, and I want to count the symptoms as I'm moving forward in order for me not to stop and read the question again. So as you can see here, there is argumentative and easily frustrated by minor requests. So we can consider that irritability. And by the way, in a state of sadness in adolescence, you should know that people with depression in adolescents and elderly people, they may present with irritability instead of sadness. So that could be considered one of the symptoms. He recently stopped participating in a school basketball team. So that means that there is decreased interest, and that's another symptom of depression. Activity has been involved for the 3 years. His father states that the patient sleeps 12 hours on weekends. So that's again sleeping too much. So that's the third symptoms related to sleep, which is considered a diagnostic, also part of the diagnostic criteria for depression. Reports feeling tired throughout the day. A recent school progress report indicates that decline in academic performance. Whenever you see decline in academic performance, that's considered decreased in the concentration. So they like to mention that instead of saying decreased in the concentration or decreased also in the work performance. Again, it's similar to saying decreased in the concentration, which is one of the criteria to diagnose depression. The teacher is noting that he appears distracted during class. On physical examination, sits and slums posture, avoids eye contact, and basically we read before that he has weight loss. So that's 5 symptoms going on for more than 2 weeks. That's enough to say that this patient has major depressive disorder. What is the diagnostic criteria for major depressive disorder? You remember it by the mnemonic SEDGE E caps. SEDGE E caps. What does that stands for? S stands for sleep problems, and we found that in that case. I stands for decreased interest. G stands for guilt. E stands for decreased energy. C stands for decreased concentration. A stands for problems within the appetite. P stands for psychomotor problem. And S stands for suicidality. You need more than 5 of these for more than 2 weeks in order to say that a person has depression. Now, another thing that I want to point out to you is that sometimes they don't have to mention it in the same way like you see it here. What do I mean by that? Is that they don't have to tell you that there is decreased energy. They don't say like that. They might mention that they don't feel like going out anymore. That's telling you that they have either decreased interest or decreased energy from being tired, or that they can say that they are tired. Same with concentration, as I told you. They don't have to say decreased concentration. They might say decreased work performance or school performance, implying decreased concentration. So that's now you know what to count as part of your diagnostic criteria. So you need to read through the question and not just expect to see the exact word mentioned to you. Same with suicidality, for example. They don't have to tell you that they are thinking of suicide. They might mention something like they wrote a will, or that they wrote a note, or that they started to distribute their personal belongings. All of these point that this is pointing towards them having a problem. Okay? Yes. Uh, what else related to this? What's also important related to this? What if you present with the same symptoms like that? Okay, but it's less than 2 weeks. It's the same symptoms, but it's less than 2 weeks. Is that depression? It's not depression. So these symptoms, while it's less than 2 weeks, what is another answer choice that could be correct in that case? You can see the answer choices here. Amazing. It would be adjustment disorder with depressed mood. What's adjustment disorder? Adjustment disorder is a diagnosis of exclusion. It's a disorder, meaning it's a problem. What I mean by a disorder is that it's affecting patient function. In psychiatry, in order for you to differentiate a normal behavior from a disorder, it has to affect function. And having these symptoms, of course, affects function. It's a diagnosis of exclusion, and it's a disorder that does not align with any other psychiatric condition. It's not aligning with any other diagnostic criteria of any psychiatric condition, anyone else other than that. And it's affecting function, and it's happening due to a stressor within the past 3 months and has to last less than 6 months. So that is actually would be aligning with someone having these symptoms for less than 2 weeks. That is not depression, but they have a problem. So that's a disorder that's not aligning with any other mood disorder lasting due to a stressor within the past 3 weeks, within the past, I mean, 3 months, and that would be the case even if they are less than 2 weeks, and less than 6 months in duration of symptoms. That has to be what adjustment disorder is. Okay. Why not D? D is normal adolescent behavior. How can this be normal? How can we differentiate a normal from a disorder? I like to just read through the question and see, is this affecting function or not? If it's significant to the degree that it's affecting function, in that case, it can't be a normal behavior. It has to be a disorder. And of course, in that question, it's more obvious because it's basically depression. It's aligning with depression. Why would you pick normal behavior if it's aligning with depression? It's more than 2 weeks of depression symptoms, then it's depression, as simple as that. So what if it's not aligning with the symptoms? In that case, it can be either adjustment or normal. So how do you know the difference? You can differentiate between any normal, by the way, any normal disorder in psychiatry, and another psychiatric disorder. Any normal, I mean behavior, and another psychiatric disorder is simply by looking whether there is functional impairment or not. So if the problem is still is affecting function, that tells you that this has to be a disorder, and in that case, it would be adjustment disorder if it's less than 2 weeks, And if it's not affecting function, then that's not depression, and that would be just no adjustment, and that would be just normal adolescent development. Okay, is that clear? Okay, what about other answer choices? Normal adolescent adjustment disorder with depressive mood, with depressed mood. We talked about that. Disruptive mood dysregulated disorder. What is this? This is a childhood disorder that leads to the child being angry all of the time, and they are constantly angry, constantly aroused, and has very bad mood. You need to differentiate this problem from intermittent explosive disorder. That's also a child who is angry, but as the name suggests, it's intermittent explosive. So it happens intermittently in explosive episodes, but between these episodes, the child would be normal. And that's different from disruptive mood because in this disorder here, they will be angry all of the time. Major depressive disorder, normal adolescent development. We talked about it, that it will not be affecting function, but let's talk about features of normal adolescent development. Normally, they can be angry and argumentative. Okay, that could be a normal behavior. They can have increased emotions over, over the other gender. So, like they can be like overwhelmingly emotional and attached to their boyfriend or girlfriend or something like that. And they will decrease attachment to their family members and their parents. And also, a normal adolescent behavior is that it would be harder for them to wake up early. That's part of normal delay in the circadian rhythm that can happen normally in adolescence. Okay? But they go to school and they communicate with other people. All of that would be normal. All of that, of course, is part of normal adolescent behavior. If they start not attending school, then now that could be a problem. If they start to have a decrease in the BMI and they are adolescents less than 18.5, for example, that's now telling you that there is probably an eating disorder. Though it's normal for adolescents to take care of their weight and to be conscious about that, but if it's starting to be less than the normal BMI, that's now could be an eating disorder. But if they're just worried about their weight and nothing else significant, in that case, that's part of the normal behavior. So as I told you, it depends on whether they reaching pathologic parameters or whether they are associated with functional impairment. Persistent depressive disorder, this is basically having a milder form of depression. You don't have to see the 5 symptoms of depression here. You can just see 3 or 4 of them going on for more than 2 years. So it's just someone who has a constant low mood and depression for more than 2 years. That's called persistent depressive disorder. Okay, let's see the next question. A 52-year-old man is hospitalized for an open reduction and the internal fixation of a comminuted femoral fracture. Which of the following is the most likely diagnosis? On his third post-operative day, he becomes agitated, begins shouting that there are spiders on the ceiling, diaphoretic, and shows a coarse rhythmic tremor of his outstretched hands. He is disoriented to time and place. Physical examination reveals spider angiomata on his chest and palpable liver edge. Neurological examination shows no nystagmus and extraocular movements are intact. There is no evidence of hystrexis, and his surgical wound is clear, dry, and intact, and there is no erythema. So, what is the most likely diagnosis in that case? What do you think? Yes, the correct answer here is that this is alcohol withdrawal because this is a presentation of delirium tremens. So, what is delirium tremens? Basically, after alcohol withdrawal for more than 48 hours, and that has to happen after 48 hours of not taking alcohol in someone who's alcoholic, they will start to develop delirium symptoms plus unstable vitals. And that would tell you some most likely it's associated with unstable vitals. Like you can see here that there is high temperature and also blood pressure is high. So having delirium symptoms, meaning agitations, hallucinations, and disorientation, and all of that, plus unstable vitals, after 48 hours of stopping taking alcohol, that's basically what delirium tremens is about. And this is usually presented in someone who has been recently hospitalized. And since in the hospital they will not have access to alcohol, in that case, that tells you that they have alcohol withdrawal. Another important pointing feature here is that they say that there is multiple spider angiomata on the chest and palpable liver edge. That's telling you that this patient probably has alcohol cirrhosis or that they have cirrhosis, raising your suspicion that now they have a problem in the liver. Along with this, after being hospitalized, that raises your suspicion of alcohol withdrawal due to delirium tremens. Okay, what else are alcohol withdrawal symptoms that you need to be aware of? Alcohol withdrawal symptoms are basically described based on the duration once they stopped taking alcohol. So between 6 hours and the 24 hours of stopping taking alcohol, you will get things like GI problems and the tremors. While if you are 12 hours to 48 hours, you will get symptoms like what? You will get symptoms like seizures and hallucinations. More than 48 hours, you get now the delirium tremens that we've been talking about, along, of course, with hallucinations, since hallucinations are associated with it. How would you treat alcohol withdrawal? How would you treat alcohol withdrawal? Yes, you would treat alcohol withdrawal by giving benzos. Amazing. Okay, what else you may be helpful regarding someone who is recently hospitalized? Listen to this. So when someone is recently hospitalized, they like to mention that in cases of alcohol withdrawal, as you can see here. Sometimes also they mention this in case of an elderly person who doesn't have any risk factors for taking alcohol or anything, but now they have delirium. Basically, it would be an elderly person recently hospitalized, doesn't have to be for more than 48 hours, but basically they recently hospitalized and now they started to be agitated. They don't know where they are and they started to hallucinate a little bit and they start pulling out their IV lines. So that's telling you that this patient has delirium. So that's another presentation that can present in someone who's been recently hospitalized. But the risk factors with this, it would be an elderly person and the following risk factors that could trigger this delirium. So an elderly person that it can be just elderly without any, by the way, mentioning anything else. But other things that they may mention is that they recently undergone a surgery, so that led to this. They basically have electrolyte disturbances. They have an infection of any kind, pneumonia, or even more commonly, a urinary tract infection. Okay, they took a medication that can trigger delirium in an elderly, like anticholinergic medications and benzos and antihistaminic medications that has some anticholinergic properties, or taking opioids sometimes can trigger this. So an elderly patient with these risk factors, or without, anyway, an elderly patient recently hospitalized, and they start to show these features, these psychiatric features of agitations and hallucinations, you should think of delirium. Okay, so far we have two scenarios. An alcoholic patient coming in for more than 48 hours and they stop taking the drugs, that's delirium tremens and the treatment is benzos. While someone with elderly patient and they have these risk factors coming in to the hospital and they basically started to develop these symptoms, that's now delirium. And what is the treatment for delirium? What is the treatment for delirium? The treatment for delirium is that you should try to treat the underlying cause. If it's electrolyte disturbances, you treat that. If it's related to a drug, you need to stop that drug. And basically, if the hallucinations and delirium is so severe, in that case, you can also give antipsychotics like haloperidol. But do you give benzos in someone with delirium? No. Benzos actually can worsen delirium, but they treat delirium tremens. Focus on that. But with delirium, they can actually worsen it. Okay? Okay, another scenario. A patient came in and they are severe smokers or they are smokers. They are mentioning smoking history. And after being hospitalized, they have irritability and they have restlessness and they have severe headache. What is that? In that case, that would be what? What do you think? Again, a smoker came into the hospital and after a few days at the hospital, they have severe headache, irritability, and restlessness. What do you think? Yes, Kara said that this would be nicotine withdrawal. And in that case, you need to offer a patch. Yes, that would be nicotine withdrawal. So three scenarios in a recently hospitalized patient, be aware of that. Along also sometimes that would be another presentation a bit far from here, but also regarding the microbiology section, that someone recently hospitalized, an elderly patient, that they took antibiotics, or even without mentioning that, they just may mention that they are recently hospitalized and now they have diarrhea, and that diarrhea could be bloody. So in that case, what would be the causing bacterial infection? What do you guys think? Yes, that would be C. difficile infection leading to diarrhea in a recently hospitalized patient, or after in a recently hospitalized patient, or after taking oral antibiotics or taking proton pump inhibitors. All of these raise the chance of developing that. Okay, let's see the next question. So the next question is: a 17-year-old boy is brought to the physician by his mother because of 5-month history of declining academic performance and behavioral changes. When you look at the last part, there is mental status examination shows impaired short-term memory and slowed processing speed, and the temperature 37, blood pressure is normal, pulse is 70, respiration is 14. Which of the following is most likely the diagnosis? 5-month history of declining academic performance and behavioral changes. The mother reported that her son, previously an honor student, has become increasingly irritable and has started skipping classes. Over the past 2 months, he has developed a clumsy gait, has fallen several times while walking at home. Physical examination shows the erythematous scaly rash areas of hyperpigmentation around the ears and the corners of the mouth. Neurological examination shows broad-based at exit gait and bilateral intention tremor and brisk patellar reflexes. And mental status examination, there is short-term memory impairment. So what do you think this is? Yes, this is an inhalant abuse. How do I know that? Simply because when I'm studying this, or when you guys should be studying this, is that you need to know that to it's linked to certain characteristic features that are found with each substance. And in case of inhalant abuse, you should know that it's common in adolescents because it's more widely available to them, and because it's cheap, and it leads to perioral rash, exactly like you see in the question here, around the ears as well. And also it leads to headache, it leads to changes in the personality, and it leads to, of course, a tremor, but tremor can happen with other things. So I prefer to remember adolescents, and I think that you should remember, and you'll see that in our files: adolescents, the rash, and the headache, and basically the slowed processing. And by the way, in the exam, questions could be a little vague. So you need to know the characteristic. You need to know the the highest, or let's say the most probable substance in each case. So sometimes they could just present a boy and he's young, and the boy is just coming with a problem, and basically it's just a headache and it changes in the personality. You could say that this is due to alcohol, which is not wrong. Alcohol can lead to also changes in the personality and lead to headache. But when they say adolescents and they give you a vague presentation like this, they understand that it's vague, and they are testing you to test your understanding, that you know what is the most common in this particular patient. What is the most common in adolescents? In that case, you would expect you to answer with inhalants. Another important tricky parts about inhalants is that sometimes you are not able to recognize what's an inhalant, because sometimes they don't write inhalants in the answer choices. They might say something else, which is an inhalant, but just not, they don't say that it's an inhalant. So you need to be aware of different types of inhalants. So glue is an inhalant. Okay. What else? What else? Butane or butane. Okay, butane and propane as well. Okay. What else? Nail polish remover, the acetone, toluene, nitric oxide. All of these are examples of inhalants that you need to train yourself to know what are inhalants, and these are important ones mentioned here. So be also ready to recognize them when you see them in the exam. Okay, what about the other answer choices? I can see that there is here alcohol abuse. We talked about that. And alcohol abuse leads to euphoria and leads to ataxia and leads to falls as well. Huntington disease, that's a disease that can affect elderly people, and that would lead to aggression, depression, chorea, and acidosis, and dementia for sure. And it's associated with an important feature known as anticipation, which is that this disease is inherited and it tends to be more severe and present early with each consequent generation having this illness. Wilson disease can also lead to neuropsychiatric symptoms. It's a disease linked to problem with copper metabolism, and copper can get accumulated in the neurons and in the brain, leading to neuropsychiatric symptoms. But that would be related also to liver problems and would related to also other findings, of course, other than the ones seen here. And cocaine abuse, that would be associated with sympathetic stimulation along with hallucinations, as we have discussed before. Next question is a 23-year-old woman is brought to the physician by her mother because of unusual behavior over the last 2 weeks. On mental status examination today, her mother is euthymic and her speech is well organized and her thought process is linear. Urine toxicology is negative. Which of the following is the most likely diagnosis? The mother reports that shortly after the patient failed a licensing examination 14 days ago, she became convinced that a local news anchor was sending her secret warnings through the television. During this period, the patient was observed talking to herself and claimed that she could hear the voices of the examiners laughing at her from the walls. These symptoms persisted for only 12 days. For the past 48 hours, the patient had returned to her baseline level of functioning, and she expresses regret over the exam performance and shows no further signs of delusions or hallucinations, and she's basically now normal. So symptoms of delusions and hallucinations for less than 1 month. What is the name of this disorder? What do you guys think? I only see 3 or 4 people answering. We have a lot of people attending. So what do you guys think? Yes, that would be that this is a brief psychotic disorder. What is this? This is basically having delusions, hallucinations, disorganized behavior, disorganized speech, or negative symptoms, basically same symptoms of schizophrenia. Which are these delusions? You need to have two of these. Delusions, hallucinations, disorganized speech, disorganized behavior, along with delusions, hallucinations, disorganized belief, disorganized behavior with negative symptoms, but usually these ones is more associated with positive symptoms, lasting for less than 1 month. That's called a brief psychotic disorder. Now, what if these symptoms last more than 1 month and less than 6 months? So what would that be? Yes, that would be that this is a schizophreniform disorder. And it's basically the same presentation, but between 1 month and 6 months. Okay, what if it's more than 6 months? So that would be schizophrenia. Okay, amazing. Now, what about the other problems here? Acute stress disorder. What is that? This is basically a patient coming in after a stressful event, usually a traumatic event, and they have hard symptoms, HARD. What is that? Hard, H stands for hyperarousal. A is avoidance. Avoidance of what? Avoidance of things similar to the traumatic event. So a patient, for example, has been through an accident, they start to avoid cars. A patient has been in a war, they start to avoid crowded spaces or things like that. R is for re-experiencing the same events, and the D is for distress. These are basically the symptoms that happen after traumatic event. If they happen more than 3 days and less than 1 month, that's called acute stress disorder. You can see all of the psychiatric conditions are about intervals and certain characteristic features. So these characteristic features for more than 3 days, less than 1 month is acute stress disorder. If it's more than 1 month with the same symptoms, that would be what? That would be PTSD, post-traumatic stress disorder. Okay, it's important to differentiate between them because acute stress disorder is managed just with cognitive behavioral therapy, while PTSD requires treatment with SSRIs, and cognitive behavioral therapy. Finally, there is delusional disorder. What is delusional disorder? This is basically that a patient has a delusion in life. It's just a delusion, just a single delusion. Other than that delusion, everything is life is normal. So basically, they have a delusion that someone is watching them. Other than that, they go to work, everything is fine, and that's what this is about. Okay? Okay, someone is asking, can you repeat hard symptoms? For sure. H stands for hyperarousal. A stands for avoidance of a similar stimuli. For example, I said, like after a car accident and they are traumatic from that, they will avoid cars. Okay, something like that. And the R is re-experiencing the same event. What does that mean? For example, flashbacks of the event or nightmares related to the event. And the D stands for distress. Okay, let's see the next question. A 23-year-old woman is admitted for inpatient psychiatric unit following an intentional ingestion of 20 tablets of acetaminophen after her boyfriend ended their 2-month relationship. Her medical record reveals 3 prior hospitalization for self-inflicted forearm lacerations and a history of multiple volatile relationships. Which of the following defense mechanisms is most likely being demonstrated by this patient? Who is during the admission interview, she tells the resident physician that she is the most gifted empathetic doctor. He is the most gifted empathetic doctor she has ever encountered, and that she finally feels truly seen for her first time in life. However, later afternoon, a different physician on the team denies her request for an immediate cigarette break due to hospital safety protocol. The patient becomes visibly agitated and screams to the entire medical team. So we talked about that already. And this seems like this patient has a borderline personality disorder, as we discussed. And these people tend to show splitting, which is that, again, black and white thinking. One doctor, just because he did something nice, he's the best person. And one, because they are just refused something, they think of them as very bad. And that's called splitting. Okay, let's see the other answer choices. Acting out. What is acting out? Acting out, or let's first understand what are these. These are defense mechanisms. So what is defense mechanism? Usually we all can face different bad emotions and threatening events that can happen in life. In order for your brain to deal with these and to adapt to them, sometimes consciously or sometimes unconsciously, leads to certain ways of our actions or certain behaviors in order to relieve that stress, in order not to make you feel with your emotions directly, in order to reduce the stress. So, for example, acting out. These are what defense mechanisms are. An example of them are seen here. Acting out. What's acting out? Basically, you have been again exposed to something stressful. And instead of talking about it or processing it or accepting it, you unconsciously start to act out, start to become angry and cause trouble. Examples of that would be things like someone recently broken up with their partner. So instead of sitting, accepting or talking about their emotions, they may go out and start drinking, or they may go out and start driving fast or something like that. So that would be called acting out. Exactly, misbehaving. Another common example is a child, they are angry because their parents are divorcing or anything like that, and then they go to school and start fights, and that would be an example of acting out. So they are under a stressful event, and in order to pass this negative energy, they start to do these actions. Next is displacement. Again, you've been exposed to a pressure, but this time it's due to someone shouting at you or someone annoying you, like your boss annoying you or someone shouting at you. So instead, again, of dealing with this negative emotions or shouting back at the person who shouted at you, it's you start to direct your negative emotions to a more safer target, to a safer target. For example, shouting at the kids at home or shouting, for example, at your partner, which would be usually safer to shout at rather than, of course, shouting at the boss. So that would be what displacement is about. Okay. So that's basically redirecting the emotions. Amazing. And it has to be from someone who you cannot shout at back, or you cannot actually form emotions to him directly. You start to redirect it to a safer target, someone that would be safer to shout at. After it, here there is projection. What is projection? As the name suggests, projection is projecting. Is that you have a negative thought, and instead of you dealing with it, and a stressful thought, that instead of you dealing with it, you start projecting it to someone else. You start projecting it to someone else. I will tell you an example to make it easier. Someone, for example, is thinking of cheating. So basically, because they are stressed by the thought, they will start directing that to their partner, for example. So someone is thinking of cheating, they may start accusing their partner of cheating. That's very different from displacement. Don't confuse it. Displacement is the boss, for example, shouting at you. You shout as at the partner or at someone else. While projection is something internally. You basically have a negative thought and you project it and you accuse someone else of having the same thought. Exactly. Sumaya is saying project an internal impulse to an external person. Amazing. While displacement is something external to something else that's also external, but just someone else. Reaction formation. That's now that you have a negative thought, but instead you don't project it, you don't reflect it, you basically do the opposite of it. So, for example, someone hates someone so much, but because maybe they feel guilty because they hate them, or maybe because they don't want to show that they hate them, they start to act the complete opposite. And I am sure that you may see that happening a lot in real life. For example, someone hates someone so much, they start when they see them to be overly smiling and hugging them, for example, because they are trying to hide what they are feeling, or because they are stressful, or they are like stressed about or guilty about feeling bad about them, so they just start to act the complete opposite. Another example, common classic example of that is, for example, a stepmother angry or feels negative thoughts about her husband's children. So instead of acting upon these thoughts, she does the complete opposite, which is starting to be overprotective over them. Okay. Yes, exactly. So Maya said the stepmom example. It's a very common and classic example. Yes. So that's what this is about. Next question is also related to these ego defenses. So a 42-year-old oncologist in the middle of the busy afternoon clinic, when he receives a phone call from his sister, who informs him that their father has just been diagnosed with metastatic pancreatic cancer. The oncologist feels immediate overwhelming sense of grief and tightness in his chest, and he pauses for a moment and acknowledges profound sadness and the urge to leave work immediately. But then thinks to himself, I cannot do this right now while my patients are waiting for their own results. I'm going to set this next news aside until I finish my rounds this evening. He then proceeds to see his remaining patients, providing compassionate, focused care without appearing distracted. That night, after arriving home, he cries, begins discussing the diagnosis with his spouse. Which of the following defense mechanisms is the patient's most likely employing in that case? So, after a stressful event, this patient consciously chooses to deal with these stressful news this way, which is setting them aside, and then after he finishes what he's doing, he's going to, feel them after, and he's going to think about them after. So that's why it's called a mature defense mechanism. Mature defense mechanisms are the conscious decision of doing that defense mechanism. Immature are like acting out and displacement. These are unconscious. These happen spontaneously without the patient thinking about implementing them. So in that case, actually, that's called suppression. This is someone suppressing the news. It's called suppression, holding the news aside till he's able to finish his work and then will start thinking about them. That's called suppression. Another example of suppression is someone, for example, waiting for the exam results. So they are stressed about that. They will decide not to think about them by basically being busy with other things like going out and enjoying things. And that's also another example of suppression. Denial is an immature defense mechanism where the patient, after being like diagnosed with a bad diagnosis or has a stressful news about someone's death or something like this, they deny it. So that's called denial, and that's a form of ego defense. And I'm sure that you may have seen this happen in life. Intellectualization is also someone being faced with bad news and they start to separate their emotions from the bad news and start talking about facts and statistics and numbers. Like someone diagnosed with cancer, they might say now they don't think about the cancer and about their diagnosis. They think about, okay, there is the chance, 50% chance of staying, staying with that cancer or living with that cancer for 10 years, something like that. They basically talk just about numbers and they separate their emotions by just focusing about intellectual facts. Um, okay. After it comes repression. Repression is unconscious, involuntary withholding of an idea or feeling from conscious awareness. How is that different from suppression? Suppression is voluntary. Repression is unconscious. Repression is immature. They basically just forget about something unconsciously. Like, for example, someone has been in a traumatic event in a childhood, they just forgot about it. They just don't remember anything anymore. That's called repression. And sublimation is that someone is basically has this negative energy and aggression, for example, and now instead of acting upon that, basically they start to channel it in a more useful ways. What would be an example of that? For example, the classic example is a child. They have they are very aggressive child, for example. Now, instead of acting upon this aggression and start to fight people, they start to channel that in a way that's acceptable by the society. For example, they play boxing, where basically they can now fight other people, but now it's acceptable. So that's what's called sublimation, and that's a mature defense mechanism. Okay. What are other mature defense mechanisms? Another mature defense mechanism is altruism. That's basically, for example, someone who does bad things, and in order to relieve the feelings of doing bad things, they start to doing good things on the other hand. Like, for example, someone who is a mafia boss, basically they do a lot of criminal activities, so they start to give making large donations, for example. So that's what that is. Something else would also be humor. That's basically that someone has been humor is basically someone um, is under a stressful event, and in order for them to deal with that stressful event, they start making jokes about it. And you can see that, for example, happening in med school where people, make memes and talk about different specialities and different study, like, different things, basically humor regarding something that's stressful, like studying, for example, or studying for an exam. Okay, so these are the 8 questions that we discussed today in our 1 hour session. I hope you guys really try our QBank. I'm sure that you'll like it a lot. You can try it for free. You can try questions for free and see if you like it or not. And also, there is a refund option. You can talk to our support team about that and ask more details about that. Uh, and basically, uh, and basically, and basically, you can also try our crash course. It's very, in my opinion, can make your life much easier along with the QBank. In my opinion, these 2 resources could be enough. It's just 1 week of condensed studying, 8 hour sessions daily. Sometimes it lasts even more than that. Basically, it's divided over, of course, systems, and the tutor will take you through the most important concepts in each system. And in that crash course, we discuss concepts. It's not like questions like this. It's also questions, but shorter questions, just so that we can dive deep more into the topic itself, so that we can have time for that. And after the crash course, after watching the session in the crash course, once you do the QBank, I think that is more than enough to pass the exam. If you do MBMEs and you're scoring enough, that means that you have studied them enough, and that means that you're ready. Also, if any of you guys is interested in our tutoring, we have the tutoring service, which can make your life much easier regarding these exams. It's basically that you get into a live tutor. You choose a tutor of your choice. We have multiple amazing tutors here. And you can, of course, try different tutors through a 30-minute demo for free with multiple tutors. You can try the multiple tutors and then pick the one that you liked the most and you liked that approach basically aligns with what you need. And basically, this tutoring is about getting you to what you need in time regarding step 1 prep, step 2 prep, and even step 3 prep as well. Basically, you have someone with you making your life much easier. It's something that I wish personally I could have had while studying for this. When I studied for step one, I spent months and months of preparation. I think that could have been much shorter if I have someone with me in sessions telling me what's important, what's not, explaining to me what I need, making me a plan and guiding me to the right resources. So that's what a tutor is about. We basically, after trying the 30 minutes for free, once you start with a tutor, they will basically, I will build you a study plan. This study plan would be daily basis over like a checklist from the day one till the day of your exam. We will know what exactly you need to do. Basically, we'll discuss together also so that we all agree on the same page. We'll know more about your schedule and build the plan accordingly. And this plan, I like to make it over a Google document because it's basically you can have access to it. I can have access to it. We can see what you're doing. As I told you, it's divided over days like a checklist. So you just check the day after you finish it. What if you didn't check it? I will be opening that every day and making sure that you check it. If you don't, I'm going to text you. If you don't respond, I can call you if you don't mind. And basically, we'll keep you consistent. And also, we'll have sessions. These sessions are going to be built according to your mistakes. How am I going to know your mistakes and weaknesses? Basically, I'm going to have access to your QBank. I'm going to have access to your nbmes. I'm going to have access to all of the resources that you had. And before each session, I'm going to study and analyze your mistakes. I'm going to pick for you the most important weaknesses that actually need discussions and build you sessions accordingly and provide you with resources that I make personally for you before each session. Me personally, like and all of the other tutors here, we put a lot of the work into the sessions. And basically, everybody's approach is different. You can try multiple people, but basically, we build you a session that's directed to what you actually need. You can try and see for the 30-minute demo, and I'll show you how that exactly looks like. And also for the NBMEs, I do through analysis of your NBME, build you a session that after this session, you don't need to actually study anything else. It's a PowerPoint presentation. I send it to you. It basically has all your mistakes, analysis of your mistakes, all of the important concepts that you need to know regarding this mistake. And basically, that takes a lot to make. And that's basically how effective the tutoring is. You'll see the benefit, I'm sure, in a matter of weeks. Then, if you guys is interested, you can try the 30-minute demo for free. Contact our support team, and they will guide you through that. And thank you, everybody, for attending. Let me send you on over the chat here the links to our to our like to how to get these tutoring and these services. You can also reach out to the MatchGuy website, and you'll find everything there. Let me send you that over the chat here as well. So this is first the link here, the link to our WhatsApp support team members. We're okay for yeah, that's the match guy and the Synapse QBank. That's the link to it as well. You can also look it up online and you can look it up on the website. You can also find the Match Guy webinars on that link. That's for the Match Guy webinar. The first link is for the Match Guy webinar channel. Thank you guys for attending this. I hope that you enjoyed it. And if any of you is interested in further help with the MBME's reviews, was basically the studying, you can come with me and any tutor of our tutors for 30 minutes for free. Try it and see if that would be helpful for you or not. Thank you, everybody, and goodbye.